what is the big deal about iron? So we're actually going to talk about the normal iron in the body and how one becomes iron overloaded in myelodysplastic syndrome or syndromes that you need transfusions, okay? And how to treat iron overload and appreciate, we don't have all the answers. So all you people who have raised your hand and had blood transfusions before, you're becoming like the Iron Man, okay? And actually, you don't want to become like the Iron Man, or you want to understand what it's all about, what's happening in your body when you receive a blood transfusion. So what we need to do is just figure out normal iron in our body. Does anybody know how much iron you actually take in your body every day? It's about 1 to 2 milligrams of iron that you actually take in. And how much do you actually get out of your body? Usually you take it out through your stool. It's about 1 to 2 milligrams. So it's a pretty closed system where you're absorbing just as much as you're losing. And in our body itself, we have about 3.5 grams of iron in our body. Does anybody know where most of it hangs out in? In the liver? Hopefully not. We don't want the iron to hang out in the liver. Actually, it's your red blood cells. Hemoglobin, heme, is iron. It's the protein that binds to the iron. So actually, in your red blood cells, there's 2.3 grams of iron just in your red blood cells. And your whole body iron is 3.5 grams, right? So most of your iron that's being used is actually in your red blood cells. Now you need iron for other processes, and the liver has 200 milligrams, and you can see muscle fibers have about 350 grams. Bone marrow has a little bit of iron in it, but most of your iron is in your red blood cells. So that's really important to understand. So what we also have to understand is iron by itself is kind of dangerous. So iron needs to be attached to a protein to make it less dangerous, right? So heme is a protein in your red blood cells, and iron connects to the heme and makes it safe for you to have it in your body. Ferritin is how you store iron in your cells, and the iron attaches to the ferritin and makes it safe in your cells for the iron to be there, okay? And transferritin actually transports the iron from your blood cell, helps you transport it in your blood, either to make it into something like a hemoglobin cell or to store it in your body, okay? So iron by itself is dangerous, needs to be attached to a protein. So, as you can see here, we have transferritin transports iron and then gives it to other processes. Ferritin, which it stores in the body, hemoglobin, 75% of our iron goes to the hemoglobin, and then there's other processes as well. So the big question today is, how much iron is in a bag of blood? Does anybody know? It's the $1 million question of the day. Is it 2 milligrams? Can anybody guess? 100 milligrams? 1,000 milligrams? One bag of blood. Anybody can guess? What do you think? 2 milligrams, you think? 2.5 milligrams or grams? Milligrams, okay. All right. You're going to be surprised. Each unit of blood contains 200 to 250 milligrams of iron. Now, if you remember your diet, you're only consuming about 1 to 2 milligrams a day, right? In a bag of blood, you get 200 or 250 milligrams of iron. So if you get 2 bags of blood, lots of people get 2 bags of blood, you are getting about 400 milligrams of iron. How are you going to get rid of it? You're not, right? Because remember, we only get rid of 1 to 2 milligrams of iron a day through natural processes. So this is kind of interesting. So then after about 20 units of blood, you have 4 grams of iron in your body. And you remember that you only had 3.5 grams to begin with. So now you've essentially doubled up the iron. And so that's how this whole iron overload thing is could potentially be a big problem, right? Because we can't get rid of the iron. How many people have had 20 transfusions before, you think? We've had a couple people have had 20 transfusions. So you're kind of going, what are we going to do? So what happens when you get extra iron? What happens is, remember that transferrin that transports iron? What's going to happen is usually we have about 30% of our transferrin being used. And what happens when your iron overload, transferrin all of a sudden is all used up. So then what happens is you have these iron that are not attached to a protein, which makes it dangerous. Remember, iron by itself is dangerous. So this is an analogy. This is my son. He's in his room. He's in his nice little cell. He's happy, right? What happens is when his sister comes in, it creates havoc in his room, right? You know, there's all this sibling rivalry and everything like that. And that's what happens when iron comes into your cell and isn't attached to a protein. It kind of messes things up a lot. So that's an analogy you can use in your head about iron and what it's doing inside your cell. It's basically wreaking havoc. So where does this extra iron go? Because we have all this extra iron. It likes to go to your liver, right? And it gets stored in your liver. So then you get some liver dysfunction happening there. It likes to go to your heart and be stored in your heart. So you can run into heart problems. And it can go into the endocrine glands, which can cause thyroid problems, diabetes problems, and reproductive issues. Okay? It also can be stored in your skin. So sometimes when people have had lots and lots of transfusions, they have sort of a grayish appearance. Okay? So that's where iron goes. It goes into the various organs and just creates havoc. Iron becomes a problem when you have 2 to 3 grams of iron in the body, and tissue damage happens when there's 7 to 15 grams, which is about 30 to 50 units. So we know this is a problem because thalassaemia, we've studied people with thalassaemia. Thalassaemia is a disorder, a genetic disorder where you're born with it and you can't make red blood cells very well. So you have to constantly get transfusions. And we know in this population, if we don't get rid of the iron, bad things start happening. And as you get older, by about 20 years, you're running into all of a sudden heart problems, diabetes, all sorts of things. So we know iron overload can create problems over a long period of time. Over a short period of time, like say 2 to 5 years, it may not cause as many problems. So if you're getting a lot of transfusions in a short period of time, you don't have to all of a sudden worry about, I have to get rid of this iron. It's more people who are surviving long periods of time where iron overload can be a problem. So iron is in a fine balance. Not much iron enters the body, not much iron leaves the body, and the body can't get rid of the iron by itself. Your body is programmed to keep every single bit of iron it can. We only get rid of 1 to 2 milligrams a day. So, and blood transfusions contain so much iron that people who have blood transfusions, you will get an excess amount of iron in your body. Okay, so is this a problem in MDS? Well, you're getting transfusions, right? So this could potentially be a problem. So they've done studies, and they looked at about 22,000 people, newly diagnosed. The median age is the average age, how many people, was 77. So generally, MDS is an older, I'll say that loosely, older person's disease, but we all know people who get MDS who are in their 30s or 40s, but generally people are in their 70s, and they saw that people with MDS who were getting a lot of blood transfusions had a higher incidence of shortness of breath, liver disease, and infections than the people with MDS who didn't receive a lot of transfusions. Okay? And a lot of people experienced some sort of heart event within 3 years, and there was an increase of death of people who got transfusions versus not. And then there was another study, a retrospective study, that people with ferritins less than 1,000 live longer than people with ferritins greater than 1,000. So you think, wow, I'm getting a lot of transfusions, I'm in trouble. But keep calm, there are opposing arguments to these studies, okay? So we're keeping calm so far. And the opposing arguments is that the data that we use for MDS, for iron overload, is very controversial because we always look back at people who've had MDS and transfusions, and we don't look forward. And good research always looks forward and gets the people and follows them through. So I don't know if you quite understand it. You sometimes say we look at people who had MDS between 1990 and 2000. That happened in the past, and then we looked and see how many people had blood transfusions and how many people had a heart attack or whatever. So that's called retrospective, looking back at data. And that's not as good because sometimes that's biased and we interpret things differently than, say, having a study where we looked at patients from 2015 to 2025, saw people with MDS and followed them and saw how many people had heart attacks and transfusions. So you can that type of research is better research because it's less biased, we think. And we don't have any research like that in MDS. So one could argue, well, the research isn't that great about iron overload. Another argument is that people who need lots of transfusions generally have a worse disease than people who don't need transfusions a lot. So there's a variability there. Treatment is very expensive sometimes. Actually, it is very expensive. And the MDS population is generally older and susceptible to other diseases anyway. So saying that, somebody who's hospitalized for cardiovascular disease, a 40-year-old, you have a very low chance of being hospitalized for a heart attack, right? But once you get into the 65, 70 range, you may have developed a heart attack anyway, even if you had all those transfusions, because genetically we're kind of predisposed for that, right? So, there's a lot of variables here that we just don't understand, and that comes into the we just don't understand part of things. How do we fix, throwing the question out to you, how do we fix iron overload? Exjade, ooh, drugs. What's the best way? Does anybody know the best way to get rid of excess iron? Pardon me? Oh, through your stool, yeah. It's a very easy one. The best way to get rid of iron is just to get rid of blood, right? You can't afford to lose it. Yeah, right. So hypothetically, say you were an MDS patient on Vidasa and you responded nicely, and all of a sudden you had a normal hemoglobin, 140, 150. We may be able to afford to get rid of some of the extra iron we gave you because you now have a normal stem cells that make blood, right? So the best way, and with transplants too, sometimes some populations of MDS are eligible to get transplants, and they're cured, and they have normal hemoglobins. So all that extra iron we gave them before their transplant, we can just take it off, okay? So, and that's why when people donate blood, you can actually, people can become anemic because they don't have enough iron in their blood. Because every time you give a bag of blood, then you're losing 200 milligrams of iron, right? If you give a bag of blood, the hemoglobin cells give 200 milligrams of iron out. Okay, so that is the best way to get rid of iron. But as you said, you can't afford to get rid of your iron, right? Because if we were to give you a bag of blood and then take it out again, you'd be just in the same spot, right? So then we get into what they call iron chelators. So iron chelators is a drug like Exjade, and we'll get into the two drugs there, that attaches to the iron. So all of a sudden you have this non-toxic molecule over here that can be excreted out of your body. And sometimes it can be excreted through your urine or through your stool. So these drugs allow the iron to actually exit your body. It gives it an exit strategy. Because remember, our bodies aren't programmed to get rid of extra iron, right? So this drug allows an exit strategy for the iron to get out of your body. So who has been on Exjade or Desferal before? Any of those? Exjade, yeah. So has anybody heard of these drugs before? Yeah, everybody's heard of these drugs. So let's just talk about when we should iron chelate. If you're a lower risk MDS and your life expectancy is greater than a year, even if you're a higher risk MDS but you're a bone marrow transplant candidate, you use either Desferal or Exjade. There's two drugs out there. And basically we want our ferritin level to be less than 1,000. And you should have received over 20 to 25 units of blood, because we know when you've received that many units of blood that you have that much iron in your system. Okay? So those are the guidelines. Now, guidelines doesn't mean that you must have to, right? Because there are different circumstances for different people. Okay? So being informed about your choices is always appropriate, but sometimes treatment may not be appropriate for you. And that's a discussion you have to have with your physician, whether iron chelation therapy is good for you. Okay? So the two drugs that we have are Deferoxamine or Desferal and Exjade. And we know that Deferoxamine actually decreases iron overload. This is just a nice little graph. The problem with Desferal is that it's a needle. It's underneath your skin. And you have to have it for long periods of time. The best way it works is for about 12 to 18 hours a day, where you have this needle underneath your skin, and it's on a pump and you have to carry around the pump. Usually people do it at night, of course, but you have to have these needles underneath your skin. And the reason why you have to have it for long periods of time is because it doesn't stay in your body very long. It gets absorbed rather quickly. It has a very, what they call, short half-life. So you have to keep giving the drug in order for it to attach to an iron and get out of your system, right? So this type of treatment has been around for a long period of time, but you can imagine with people with, say, who are younger, who were 15 or so and had thalassaemia and had to have these injections had to have this all the time, that they weren't very compliant. And that was the biggest problem with this type of treatment. And the side effects, you can get a lot of where the needle goes in, usually in your stomach, you can get redness in that area, and you always have to watch out for eyes and ears when you're on iron chelation therapy. It doesn't matter what, even when you're on Exjade, you have to watch your eyes and your ears because you can have hearing loss with that. And you can have allergic reactions. And sometimes, like every drug, it can cause nausea, vomiting, diarrhea. So, like I said, with Desferal, there is, sometimes people don't like to take it, right? So they don't like to have this pump with them, they don't like the side effects, and people don't use it properly, right? Especially they found in the thalassaemia group, if you didn't do it 5 or 6 times a week for 12 to 18 hours, it didn't work very well. But the government does fund this, and it does help for some people, and there are ways which we can maybe modify it so that the Desferal goes through a PICC line or other ways like that. So not to say it's not a good drug, it is good and it works, but sometimes people have issues with doing it on a regular basis. So there is another drug, which is a pill, which is great, right? You have a pill, it's called Exjade. People who've had Exjade before, it's a dissolvable tablet that you have to stir in to some water and drink it. So you can mix the Exjade and stuff, but this isn't perfect either. Anybody know what kind of side effects you can get from Exjade as well? Diarrhea, yes. And you know why you get diarrhea? Because that's how you're losing the iron, right? So people have a lot of GI problems with it. So a lot of times we'll start little on the Exjade and kind of work our way up because the diarrhea can be rather cumbersome. That's the biggest thing. And you can get skin rash, right? So you have to watch out for those skin rashes, and we always have to watch out for kidney function as well, right? So it's not perfect as well, but certainly it's a lot better sometimes than getting those injections. Some ways to cope with it is changing the dosing from day to night sometimes, so that your GI system is settling just after you took your Exjade at night. Avoiding dairy sometimes is good. Using antidiarrheals such as Imodium once you've figured out that the diarrhea is related to Exjade, as you want to make sure you don't have like C. diff or something like that either, right? So you have to tell your doctor that you're having diarrhea, and then they can determine whether this is because of the drug or something else. Always important before starting up Imodium, okay? Lots of fluids. Always important to drink lots of fluids. Steroid cream sometimes we use for the rash, and antihistamines because like Benadryl if it's really itchy things. And the biggest take-home message, drugs don't work in patients who don't take them. So as a practitioner, I assume when I write a prescription that you will be 100% compliant and take your medication exactly the way I told you to. And you're going, yeah, no, not. I'm terrible at taking antibiotics, right? I always, it's 10 days and then 12 days later, I still seem to be taking those antibiotics, right? It's really, really important to take medication properly. Because if you come back to us and say, it didn't work, we're gonna be all, oh, it didn't work, what else are we gonna do? And change things up. But if you didn't take it properly, then we didn't allow the drug to work to begin with. And that's for any drug that you get, your high blood pressure pills, your diabetic pills, whatever you're taking. It is really, really, really important to be as what they call compliant as possible, or taking your medication the way you are. And if for some instance you aren't, please be upfront with us, okay? And say, yeah, I didn't take it for the last week because of this. Letting us know is way more important than us going, oh, what are we gonna do next now? Because then we can work with that. And we can work with, maybe you're having lots of side effects on medications, right? We can work and help you try to get through those side effects. Okay, so that's the big number one thing, is be upfront and honest. Try to take your medications as they're prescribed, and if you're not, tell us, okay? That's the big one here. And the more take-homes, keep track of how many transfusions you're having. Sometimes we practitioners forget, oh my goodness, that person has had over 20 transfusions and we haven't talked about iron overload. So this is something that you can do for your health, is that keep track of those transfusions and then ask, what about iron overload? And like I said before, treatment may be good for you, it may not be good for you. You have to weigh the risks and the benefits, okay? So that is very, very important. Not everybody, treatment of iron overload is appropriate for everybody, okay? So I don't need people going, well, that lady said I had to. You want to make sure that you talk with your physician and understand why or why not you should go on iron chelators. Avoid multivitamins that have iron, because you have enough. It's just that your body can't make enough iron, or make enough hemoglobin cells from the iron that it has. So there's a whole process to make a hemoglobin cell. Iron comes in here. The problem with MDS is that the problem is back here. It's not because you don't have enough iron. Some people would have iron deficiency for other reasons, say if they've lost a lot of blood, or have sometimes women, we tend to lose a lot of blood lately at some points in our lives, and we become iron deficient and anemic because of those processes, okay? So always good to understand why you're anemic. Is it because you don't have enough iron, or is there a problem somewhere downstream that's a problem? And like we said before, avoid raw shellfish, because they have bacteria that like to feed off of iron. And if somebody has a lot of iron in their system, they're gonna just have a nice party and a heyday, okay? So you need to cook things.